when I started my work in El Salvador, watching how bans played out there and seeing much the same, I always wondered, like, will any of this be relevant outside of a developing country where the systems of the mechanisms of the systems of justice are so underdeveloped compared to the sophistication of our legal system and our medical system? They're so under-resourced. And I often assumed, yeah, this wouldn't happen in the States, but it's a nice example. And it turns out that I was wrong, that in fact, much of what I saw there is happening right here, right now. Michelle Oberman. I'm a professor of law at Santa Clara, and I have been here actually 20 years. And over the course of the 20 years that I've been here, I have been teaching both in the criminal law field and in the health law field. And in particular, I'm interested in the things that happen at the intersection of pregnancy and criminal law. And because of that interest, I've spent the past maybe 10, 15 years looking at what changes on the ground when abortion laws change on the books. And specifically what I mean by that is I'm interested in, when you make abortion a crime, how does that work in the 21st century? And the interesting thing about where we are right now in this country is that we're in a very different place than abortion opponents expected us to be when they got the permission in 2022 to ban abortion again. So when Roe versus Wade was reversed, around 14 states around the country quickly moved to make abortion a crime. And they probably assumed that abortion rates would drop when abortion became a crime. And what we've seen in the past 2 years is actually that the rates of abortion have increased, that more abortions are happening every year today in 2025 when we're talking than were happening in 2022, or in fact in any of the recorded years since the 1970s when we first started tracking it. And the question is why? And the answer is that people tend to have abortions when they feel like they cannot have a child. And there's lots of reasons why somebody who's pregnant might feel like they cannot have a child. Some of the most common ones are that they already have a child and that they're struggling with money. 60% of abortions go to people that already have at least one child. And the rates of abortions vary by class. So while people have abortions across the full socioeconomic spectrum, 75% of abortions in this country go to folks that are either below the poverty line or just above the poverty line. So people have abortions when they feel like they can't afford to have a child. So knowing that, my research interests and my work actually overseas, studying what happens when abortion is banned, led me to set up a study that started as soon as abortion was banned in this country. And I went to a state where abortion is now illegal, and I recruited a pool of doctors. So from the beginning, I had my eye on adolescent medicine doctors, doctors who treat teenagers. Right? And the reason I did that is because teenagers have a disproportionately high rate of what we would call unwanted pregnancy. They get pregnant, they weren't using contraception, and they feel like they can't continue the pregnancy, and so they're seeking to end it. They're seeking abortions. I knew from my work in Central America, where I had spent around 10 years studying the impact of an abortion ban in El Salvador, that adolescents have a disproportionately hard time accessing abortion when it's illegal. And the statistic that really haunted my research there and led to this project that I'm working on now is the statistic that the highest rate of maternal mortality, the number of people who die during pregnancy in El Salvador, is teenagers, where 3 in 8 maternal deaths are happening when teenagers take their own lives. Pregnant teenagers take their own lives. So that statistic had me from the beginning recruiting doctors into my study and asking them questions about how their patients were faring. By the second year of my interviews, so by the summer of 2024, it was clear that the obstetricians in my pool had figured out how to provide most of the necessary care that they needed to provide in order to keep their patients safe, and that the adolescent medicine doctors were having an entirely different experience. Their patients were only accessing the necessary care if they had a supportive adult in their lives, and the poorer and more marginalized the population of teenagers, the less access they had to the means for ending their pregnancy. What's been interesting with my doctors is to watch them struggle to treat their patients. One of my doctors put it this way. He said, the work is to keep my head above water, but under the radar. Because what I want to do is be able to treat my patients to the full extent of the law. I don't want to provide shoddy care. I don't want to provide incompetent care. I want my patients to live, right? And so there's a very earnest desire to be able to do the maximum possible to do good by your patient, to heal your patient. But at the same time, if you are too out and proud about it, too vocal, or perhaps not paying full attention to who else knows about the care that you're providing, you could in fact find yourself in trouble, not because you were providing bad care or illegal care, but because somebody thought you were, and that could then really jeopardize your ability to treat other patients. So if you think about that little margin, if you're sort of keeping your head above water and under the radar, it's that feeling that typifies my doctors across the board. They're trying to practice in a really hostile environment when all they went to medical school for was to be able to treat their patients, right? That was their goal. And instead they're finding themselves really squeezed. And that's become perhaps the most interesting part of the work for me, is finding myself writing for medical audiences and trying to get the profession as a whole to step into the vacuum and the sort of the dislocation, the chaos that's been created by lawyers changing medical practice, right? I mean, lawyers who didn't go to medical school have changed the law, and the law doesn't map neatly onto the complicated world of pregnancy. So the biggest similarity between what I witnessed working in El Salvador on abortion issues and what I'm seeing here is the differential impact on the poorest and most vulnerable and marginalized populations. So in El Salvador, your ability to access an abortion under the ban turned on access to a trusted confidant who could help you figure out your way to ending the pregnancy. So you needed a network of somebody who had the information and could walk you through it. And there, oftentimes, it's a small rural country. So you'd go to the trusted woman in the village, and the midwife or the woman in the village would then help you figure out how to get on a bus to the nearest town where you would buy the pills, and then help walk you through, accompany you through the use of the pills to end an unwanted pregnancy. And amazingly, really, 1 in 3 pregnancies in El Salvador end in abortion, which again is a very high rate, higher than we've ever been. Our rate here was, prior to Roe, something like 1 in 4, 1 in 5. We've never been a 1 in 3 pregnancies ending in abortion. But to my point earlier that abortion is what you do when you can't afford to have another child, in El Salvador, people are living on an average of $5 a day, right? So when you take that particular sense of what happens and you move it to the United States, you find actually a similar pattern in that the folks that are struggling most with access are the rural, the marginalized economically, and youth, right? The youth population are the ones that are going to struggle to access the ability to move themselves from place 1 to place 2, from the place where it's illegal to the place where it's legal. Or even to move themselves with confidentiality and anonymity from where they are sitting at home on their phone trying to figure out the algorithms to how do I figure out how to access the medicine that I'm going to need if I want to end this abortion. the key linchpin in the United States and in El Salvador ends up being a trusted adult to help guide you through the process. So the wealthier you are, or the stronger your relationship is with somebody who is trustworthy, the easier time you'll have securing your own reproductive and, let's face it, life autonomy, right? The easier time you'll have being able to control, at least in the short run, the trajectory of your life. So you're a 14-year-old, you don't want to become a mom right now. If you don't have a trusted adult in your life, then there's a really good chance, a much higher chance for the 14-year-old than the 24-year-old, that you're going to end up being forced to continue the pregnancy. And just to be clear, being forced to continue an unwanted pregnancy is associated with a huge host of really complicated mental health and then health compromises that we're only beginning to take the measure of. I mean, when my adolescent medicine doctors are asked, what's the impact on your patients of having to carry an unwanted pregnancy? I mean, look, I interviewed 20 of them. I'd say half started to cry. My sense is that the doctors tend to exhibit one of three classic responses to trauma: fight, flight, or freeze. Some of the doctors have really become very powerful advocates. A couple of the doctors in my sample have been very active in going to testify before the state legislature, in becoming spokespeople for ballot initiatives to try to overturn the state ban. They've just, they've really felt called into action. Many of them are also fighting institutionally so that they're working within their hospital systems to try to get the support that they need to be able to counsel their patients about the access to abortion that adult women would be able to figure out. So to be able to say to their patients confidently, here's a state that you could go to, and here's the money that you need, here's the resources that you need to get you there, even if you don't have a trusted adult, right? But they need the institutional backing, and they are fighting for it. The other cohort, just as robust and more troubling, are the doctors who are just leaving practice. And I mean, within my initial pool of 25 doctors, the most vivid example of this is an adolescent medical doctor who, the first summer when I met her, she practices in sort of the inner city, a very marginalized population of adolescents. And I asked her how she was prepared to face the impact of the ban on her patient population. And she said, some people just run toward the fire, and I'm one of these people, right? By the second summer, she said, this is impossible. Just providing this care is impossible right now. None of my patients are getting out of state. And watching a population of patients that includes kids that are already in the foster system, that have been abused and neglected as children, and now they're pregnant as the result of abuse and being forced to continue a pregnancy that is likely to be lost to the foster care system, just as they were. This doctor, by the second summer, was just, and she was 50. Like, this was a doctor who was at the peak of her professional acumen and career. By the third summer when I went back, she said, I'm so glad you're here in June this year because I'm moving to Canada next month. So, and we're seeing that pattern across the country. We're just not really sure what to do with it. And then there's the doctors who freeze. And I think those are actually sort of the majority. And they're sitting in the moment. The teenager says to them, I can't carry this pregnancy. And the doctors freeze. And they say, well, I can't talk to you about it. Right. And that experience of freezing really causes a corrosion in the quality of the doctor-patient relationship. Suddenly there's no trust. Right. It causes the doctor to experience what we call maybe moral injury, where they feel like, okay, I'm looking at this patient, I know what they need, I have that information, and I'm not giving it to them. And so that freezing experience, which I think is the most common, then turns into a flight from the profession. Like, I just, this is not tenable, I can't keep doing this. And so, I mean, I think the most hopeful goal of this project is that we figure out ways to maximize the capacity of folks treating adolescents to do their jobs and to just quiet down what I think of as really remote risks of legal entanglement, and allow them to support their patients. Because without that, I just don't know where this ends. So after those results started turning up in my research, I reached out to two really terrific adolescent medicine specialists at the University of California, San Francisco, which has a really top tier medical school in the country, a school that's known not just for training fantastic doctors and providing excellent care, but also because it has a really robust research agenda. And these two doctors worked with me to design a study that it's a mixed method study. So it has a survey component, which we've already completed, and then an in-depth interview component, which we're just now in the process of completing. So what we did is, working together, we designed a study that went out to adolescent doctors throughout the country. We surveyed 235 doctors in both banned states, states where abortion is illegal, and access states, states where abortion is legal. And we asked about what's changed for them since Roe v. Wade was reversed. So who are they seeing as adolescent patients? How are the adolescents coming to them, and what's different in terms of the care that they provide? And as you can imagine, a lot changed, a lot changed. So we started to hear about changes in their confidence prescribing and counseling and treating patients, because just say that you're in Illinois, but you're treating a patient from Iowa. Well, you now need to know what's legal and illegal in Illinois, and you also need to know what they're facing when they leave to come to you for an appointment, and when they go back. You need to be able to counsel them about things that you did not get trained on in medical school. Like, who do you tell? What do you tell? Don't put this on social media, right? Don't tell your friends, right? There is a sense of risk and vulnerability, even though we've seen very few prosecutions, almost no prosecutions of clinicians, of doctors, and very few of people who are ending their own pregnancies, but still there's reason to be cautious. So the inconvenient truths right now involve teenagers having babies they can't afford, and then all of the downstream costs, what we call the medicalization of poverty, like what happens to that fragile family when they now have a baby. So the costs of housing, of education, of employment, of healthcare, all of those costs are being saddled on the population that can least afford it. And the long-term implications of those costs for those children can't be celebrated as a pro-life victory unless and until we're ready to build in the supports needed for those families to thrive. And so while I don't spend a lot of time figuring out how to message this work for an audience that supports the abortion ban and that thinks abortion is a bad thing and that wants those babies to be born, the message that you'd have to agree on is we have to make it more affordable to have a child. We have to make it so that it's not like your life is over from the moment that you become pregnant as a teenager. I mean, just to put a really fine point on it, the single biggest change in cost and income after you have a baby is $100 a month just to afford diapers, and that's the minimum, right? The ideal amount of diapers is closer to $200 a month. Babies that have diaper rash in this country encounter all sorts of problems, right? It's sort of astonishing that 1 in 5 babies in this country doesn't have adequate access to diapers, right? So we're not even talking about the housing or the healthcare or the leave from work or the flexible work hours. We're just talking about keeping your baby in diapers, and our country's not even supplying that. So these facts are actually facts on the ground that are changing as we speak. And everybody should agree that if we're going to force people to have babies they don't want, we should make it easier for them and for the babies to thrive.